Hello friends, let us now learn some important points about Meniere's disease or Endolymphatic Hydrops. So, this Meniere's disease or Endolymphatic Hydrops is the disease of membranous inner ear. It is a disease of membranous inner ear. Here the patient suffers with a triad of episodic vertigo, fluctuating deafness, fluctuating tinnitus. So if you see the incidence, in the incidence of Meniere's disease, males is more commonly seen than females. Most commonly it is seen in 35 to 60 years of age and it is generally unilateral. So if you see the pathophysiology, here first and foremost endolymph moves from cloaca, that is site of production, to the endolymphatic sac. It moves from cloaca to the endolymphatic sac, that is site of absorption. So whenever there is any disturbance in production or absorption of this endolymph, whenever there is any disturbance in production or absorption of endolymph, this will cause accumulation of endolymph in cochlea or in membranous labyrinth. Because of the accumulation of endolymph in cochlea or membranous labyrinth, it causes symptoms. If there is accumulation of endolymph in the cochlea, it causes hearing loss. If there is accumulation of endolymph in membranous labyrinth, it causes vertigo. Clinical features of vertigo: the patient shows sudden onset of sudden episodic nature of vertigo, which will increase over a period of minutes, and it also lasts for several hours. This vertigo is also associated with nausea. It is associated with nausea, vomiting, pallor, sweating, diarrhea, and bradycardia. There is no loss of consciousness is seen. Then we will also see fluctuating hearing, sensory neural hearing loss is seen. Initially, this sensory neural hearing loss is of low frequency hearing loss. Later, there can be both high and low frequency hearing loss may be seen. Then here we will also see diplocusis, that is the sounds are louder than normal, and we also see presence of recruitment phenomenon, that is recruitment phenomenon is intolerance to loud sounds may also be detected. Then there can be tinnitus. This tinnitus is a roaring type or fluctuating type of tinnitus is seen, and it is also associated with oral fullness and Tullio's phenomenon. It is associated with Tullio's phenomenon, that is Tullio's phenomenon is actually a subjective imbalance. Tullio's phenomenon is subjective imbalance and nystagmus, which occurs in response to loud low frequency noise exposure. So subjective imbalance and nystagmus, which occurs in response to loud and low frequency noise exposure. It occurs due to distended saccule lying over the stapes foot plate. Now if you see the other clinical features, this Meniere's disease is also associated with drop crisis or otolith crisis of tubercles, where you will see presence of sudden drop attacks without loss of consciousness. The patient presents with sudden drop attacks without loss of consciousness. Here you will see no vertigo or fluctuation in the hearing loss. Pathologically, there will be deformation of otolith membrane of utricle and saccule occurs due to dilatation. Next if you see nystagmus can be divided into three phases: first phase, second phase and third phase. First phase nystagmus is an irritative phase where nystagmus is horizontal and beats towards the affected ear. whereas the second phase is called as paretic phase, where nystagmus is horizontal and also beats towards the affected ear. Then third phase is called as recovery phase, which is also the same, where nystagmus moves or beats towards the affected ear. Now if you see the investigations, in the investigations the tuning fork test is done, and if you do the tuning fork, you will see that there is, so tuning fork test is done. In the tuning fork we will see that there is sensory neural hearing loss is seen. Rennie's test is positive because it is sensory neural hearing loss, and Weber's test is towards the normal ear, and Squabach test is shortened. These are the features of sensory neural hearing loss which are seen in Meniere's disease. Then pure tone audiometry. In pure tone audiometry, sensory neural hearing loss, early stages, you will see that the curve is of raising or unsloping type at lower frequency. In later stages, the curve is flat and falls down, and it is falling type at higher frequency. So at early stages the curve is raising type in lower frequency, whereas at late stages the curve is flat or falling type at higher frequency. So in pure tone audiometry, 42% have flat audiogram, 32% have peaked pattern, whereas 19% have downward audiogram, whereas 7% has rising pattern. Then we have speech audiometry. In speech audiometry, the discrimination score is equal to 55 to 85%. Recruitment is present in the Meniere's disease. Recruitment is present. Then if there is brainstem evoked response audiometry, in this we will see that there is presence of reduced latency of wave 5 is seen in Bera audiometry. Then if you do electrocochleography, actually this electrocochleography is most sensitive and diagnostic. In the electrocochleography we get the summating potentials and the action potentials. If the division of summating potentials with the action potentials, if the ratio of summating potentials with the action potentials is 1.3, that is equal to 0.33. Normally it is less than 30%, but in Meniere's disease it is more than 30%. Normal width of summating potential to action potential is equal to 1.2 to 1.8. Normally it is 1.2 to 1.8, but in Meniere's disease it is 1.3. If you see in percentages, more than 30 to 40%. Then we have caloric test, where you will see presence of canal paresis. Then we have glycerol test. This glycerol is given parenterally, and this glycerol will also produces decrease in intralabyrinthine pressure. Glycerol produces decrease in intralabyrinthine pressure, and it also improves cochlear blood flow. Improves cochlear blood flow, and thus in the glycerol test there is improvement of hearing loss occurs, or there is increased discrimination score occurs by 10. Then we have reverse glycerol test. In this reverse glycerol test is performed using acetazolamide. This reverse glycerol test shows deterioration in pure tone thresholds, and it also shows speech discrimination score. It shows deterioration in pure tone thresholds and shows speech discrimination score. So now we will have to learn about the diagnostic evaluation. So in the diagnostic evaluation of Meniere's disease, first and foremost we can do audiometry is done to the patients, is done in the patients. In diagnostic evaluation we can do audiometry, and all the tests which were described above can be done. And one more test which is done is fluorescent Treponemal antibody absorption test is done. Treponemal antibody absorption test is done. This is done to rule out syphilis. Then we have Committee on Hearing and Equilibrium of American Academy of Otolaryngology. Committee on Hearing and Equilibrium of American Academy of Otolaryngology, that is head and neck cancer is. So first we have certain factors include, when you can say that the Meniere's disease is certain if we do definitive Meniere's disease being confirmed by the histopathology. If Meniere's disease is confirmed by histopathology, then we say certainly it is Meniere's disease. Definitive diagnosis is given if 2 or more definitive spontaneous episodes of vertigo are seen more than 20 minutes or longer, or if there is audiometrically documented hearing loss is seen at least on one occasion. If audiometrically documented hearing loss is seen on at least one occasion, or if there is tinnitus or oral fullness is seen in the affected ear, and all the other causes should be excluded. All other causes being excluded. So these are the definitive diagnosis of Meniere's disease. Then if you see the probable diagnosis of Meniere's disease, in this, one definitive episode of vertigo with audiometrically documented hearing loss on at least one episode, one definitive episode of vertigo with audiometrically documented hearing loss on at least one occasion, and if the patient suffers from tinnitus or oral fullness in the treated ear and other causes being excluded, then in all these cases we call the diagnosis as probable diagnosis. Then we call it as possible diagnosis if there is episodic vertigo of Meniere's type without documented hearing loss. We call it possible diagnosis of Meniere's disease. And if there is if the patient is suffering from sensory neural hearing loss which is fluctuant or fixed with disequilibrium without definitive episodes and other causes being excluded, then we can call it as definitive episode, then we call it as possible cause of is Meniere's disease. Then what is important is these variants of Meniere's disease are important. In the variants of Meniere's disease, one we have cochlear hydrops. In cochlear hydrops, only cochlear symptoms are present. Vertigo is absent and appears only after several years. In cochlear hydrops, you will see only cochlear symptoms. Vertigo is absent. And there is block at ductus revinus occurs, and because of the block in ductus revinus, it causes increased endolymphatic pressure which is confined to only cochlea. Then we have second one which is called as vestibular hydrops. In vestibular hydrops, here typical episodes of vertigo are seen because here the cochlear function is normal. Cochlear function is normal and the defect is in vestibular function. So you will see episodes of vertigo, and we will also see typical picture of Meniere's disease develops with time. Typical picture of Meniere's disease develops with time. These are vestibular hydrops. Then we have Larmoya's syndrome. Larmoya's syndrome, here the symptoms are seen in reverse order. First, there is progressive deterioration of hearing occurs. Progressive deterioration of hearing occurs, which is again followed by an attack of vertigo. Progressive deterioration of hearing occurs, which is followed by an attack of vertigo. This is Larmoya's syndrome. Then if you see the treatment, in the treatment first we see medical management. In the medical management, initial treatment is with medical management. We will have to try to control the condition in more than 2/3 of the patients. We will have to try to control the condition in more than 2/3 of the patients. First, there are antihistaminic labyrinthine sedatives, or we have vestibular sedatives. So these antihistaminic labyrinthine sedatives or vestibular sedatives include we have chlorperazine, promethazine and cinnarizine. These include prochlorperazine, promethazine and cinnarizine. Second are anxiolytics or tranquilizers can be given, like we can give diazepam can be given if the patient is anxious. If the patient is anxious, diazepam can be given. Third drug, we can also give vasodilators to the patient. Vasodilators like beta histine hydrochloride can be given. This beta histine hydrochloride is the most useful recent vasodilator. It is the most useful recent vasodilator. This beta histone vasodilator will increase the labyrinthine blood flow by releasing histamine. It increases labyrinthine blood flow by releasing histamine. Then other drugs like other vasodilators like nicotinic acid, thymoxamine, inhaled carbagen like 5% carbon dioxide and 95% oxygen, and histamine drip, all these can be used. Now, in order to increase the vascularity of endolymphatic sac and duct, to increase the vascularity of endolymphatic sac and duct, we should increase the reabsorption of endolymphatic fluid. This will increase the reabsorption of endolymphatic fluid. Then diuretics or furosemide. In diuretics and furosemide, diuretics with fluids and salt restriction can be given to these patients. Then fifth drug. Other drugs include, we have other drugs like propanthelene bromide, phenobarbital and hyoscine can be used. Then we also have one more device which is called as Meniere device. This Meniere device is actually an intermittent pressure. Through this, with the help of this Meniere device, intermittent pressure is delivered to the inner ear, and this will improve the symptoms of Meniere's disease and it will improve the hearing. Thus, this device is called as Meniere device. It will improve hearing, and this device is called as Meniere device. Now, the second important group of treatment is by giving labyrinthine exercises. Now, labyrinthine exercises are actually started by Cooksey and Cawthorne exercise. Cooksey and Cawthorne exercise can be adopted for labyrinth, can be done for adaptation of labyrinth. Then we also have surgical management. In the surgical management, first there is intratympanic gentamicin therapy or chemical labyrinthectomy can be done. Intratympanic gentamicin therapy or chemical labyrinthectomy can be done. Here gentamicin is vestibulotoxic. This gentamicin is used daily or bi-weekly injection into the middle ear. It is used daily or bi-weekly injection into the middle ear. Here the drug is absorbed through the round window, and this drug which is absorbed causes destruction of vestibular labyrinth. When it causes destruction of vestibular labyrinth, as a result, it can cause side effects like vertigo spells, because the vestibular labyrinth has been destroyed. So once this gentamicin destroys the vestibular labyrinth, obviously the endolymphatic pressures will decrease, thus the Meniere's disease will come down. Next we have microwick. In the microwick, a small wick is made up of polyvinyl acetate is put in the ear and it measures 1 millimeter into 9 millimeters. This microwick will deliver the drug from external canal to the inner ear. It delivers the drug from external canal to the inner ear. So thus we can avoid the intratympanic injection because it directly delivers from external ear to inner ear. But this microwick application requires a tympanostomy tube or grommet insertion into the tympanic membrane. Now if you put the grommet, you will insert a grommet, and if you put the wick in the external canal, through the grommet the medicine will pass from the wick and it is delivered into the round window, and this drug is then absorbed into the inner ear. Then we have the second surgery which can be done, which is called as endolymphatic sac decompression. Here in endolymphatic sac decompression, pressure of the sac is relieved. So for relieving the pressure of the sac, we can give either a local anesthesia or general anesthesia is given to the patient, and then we do simple mastoidectomy, and 3 semicircular canals are also lineated. Then bone in the area of Donaldson line is cut. Bone in the area of Donaldson line is cut with a diamond burr, and this will expose the sac. And later it relieves the pressure in the sac. So this will relieve the pressure in the sac, thus it will relieve the symptoms, because once the pressure is decreased, obviously the symptoms are decreased. So here what do we do in endolymphatic sac decompression is we give local anesthesia or general anesthesia, and then we do simple mastoidectomy, and we will cut the semicircular canals, and we will also relieve the pressure by just cutting the semicircular canals. So thus the pressure is relieved. Then we have the third operation, which is endolymphatic shunt operation. In this endolymphatic shunt operation, a tube is put between the subarachnoid space and the endolymphatic sac for drainage of excessive fluid. For drainage of excessive fluid, a tube is put between the subarachnoid space and endolymphatic sac. Then we have sacculotomy or fixed procedure. In this, a saccule is punctured with a needle through stapes footplate. And in the sacculotomy, one more important thing is there is Cardi stack procedure. This Cardi stack procedure will place a stainless steel tack to periodically decompressing the sac. So in Cardi stack procedure, we place a stainless steel tack to periodically decompress the sac. So with the help of this stainless steel, like a needle like thing, we will periodically decompress the sac and remove the excess fluid which is there. Next, so these are the main operations which you do for Meniere's disease. Then we have secondary endolymphatic hydrops also. Secondary endolymphatic hydrops are the differential diagnosis of Meniere's disease. These include viral infection, syphilis, endocrine or hypothyroidism. These can cause autoimmune, trauma, allergy, Paget's disease, acoustic neuroma, and these include vertebro-basilar insufficiency and migraine. So these are the main causes of secondary endolymphatic hydrops. These secondary endolymphatic hydrops are also the differential diagnosis of Meniere's disease. Thank you for watching.